Speaker, Dr. Shreyas Ramamurthy, who's going to tell us points to ponder on phakic IOLs in keratoconus. Dr. Gaurav, yes, I'll remember you are there. I'll ask you the next question. You have to unmute yourself, Shreyas. We can't hear you.
Yeah. Can you hear me now?
Yes.
I had unmuted myself. I think they had muted everyone. Yeah. So essentially, when do we perform phakic IOL in keratoconus patients? Either patients who have stable keratoconus or already have been cross-linked and are now stable. Patients with good spectacle corrected visual acuity, that's extremely important. And then about whether they have a centered or decentered cone, which I will deal with in subsequent slides. So we follow generally either if it's a patient is already having stable keratoconus because of age beyond 30, or if it's cross-linked, you wait for at least 2 stable refraction and 2 stable topographies with a minimum of 6 months or maybe more before you would contemplate a toric phakic intraocular lens. So for a patient with progressive keratoconus stabilized by cross-linking, if it's a central cone with good spectacle corrected visual acuity, then you could either do a cross-linking with the topo-guided PRK, and then for the residual error, go ahead with toric phakic IOL. But if the patient has an eccentric cone or the best spectacle corrected visual acuity is poor, then these patients are very poor candidates for any kind of phakic IOL procedure. So you would probably do well to do with the intracorneal ring segments, especially if the pachymetry is poor. The pachymetry is good, you could also try a topo-guided treatment and see if the BCVA improves. And if it improves, then you could subject them to a phakic IOL. So I'll just run you through a couple of quick examples. This is a patient with a very mild early KC, which was just observed. But the fellow eye of this patient had a more advanced keratoconus. Though it's a central cone, the best corrected visual acuity is very poor. But because of this kind of significant anisometropia, this patient cannot wear spectacles. And these are excellent candidates for introducing a phakic intraocular lens. But contrast that to a patient who has only a 624 best spectacle corrected visual acuity. For these patients, CXL alone and thickness is quite low, so you can't do any other ablative procedure on the cornea. These are good candidates for intacs. And once you've done the intacs, you can see that the cone has become a far more regularized. The spectacle corrected visual acuity has improved to 6.9, and now you could subject them to a phakic intraocular lens. And with a phakic intraocular lens, post intacs also, it works extremely well. It's very important that we ensure that we have a repeatable refraction. Patients who are not comfortable with their spectacle corrected visual acuity will not be happy with a phakic intraocular lens, and that is something we must remember during this treatment. Specific issues with regards to phakic IOL in keratoconus, these patients will have an abnormally high central anterior chamber depth, and therefore their white to white diameter, which can accurately be measured, will not correlate with their central anterior chamber depth like in normal patients. So there is a poor capacity to predict the peripheral anterior chamber, to predict the central vaulting. As we all know, the ratio between the central anterior chamber depth and the peripheral anterior chamber depth is altered in keratoconus. So you can have a patient with the same white to white but very different vaults, or you could have a patient with a similar vault, but you can see that the angle is wide open in one case and quite narrow in the other. In extreme scenarios, you could have the phakic intraocular lens actually popping above the pupil and actually having a kind of an optic capture because of the high vault. And in these cases, you have no other choice but to explant this and go ahead with a slightly smaller sized lens. So the caveats that I would like to highlight here is that patients with a higher ACD go for one size smaller than what you would in a normal refractive procedure. These patients may need customized lenses. Avoid contact lens users because they are generally very unhappy with spectacles or phakic IOLs. Vision less than 612, again, they are not very happy. I'll conclude in a minute. I'll just take you all through. You could also do this post-DALK when they are, once the sutures are out and they have a fairly regular astigmatism and good spectacle corrected visual acuity. The procedure can be done post-DALK as well, and it will be quite useful. So we did a study of about 126 eyes, a retrospective study of patients who have undergone phakic IOL in keratoconus. We used toric ICL and IPCL. All were stable keratoconus patients. As you can see here, the age group is a little older than the regular refractive cohort at the age of around 30. The Kmax, again, not very advanced keratoconus, around 54. What is heartening is 80% of patients were within half a diopter of spherical equivalent and 90% were within plus or minus 1 diopter. These are all keratoconus patients, which is a good outcome. And patients beyond 6/9 vision, 70% pre-op BCVA, but 86% post-op BCVA. 39% of patients gained 1 or more lines of best corrected visual acuity with the phakic intraocular lenses. We also did a quick subset analysis of low astigmatism versus high astigmatism and found high astigmatism patients did just as well. Both ICL and IPCL patients did very well. Even patients with a decentered cone, as long as their spectacle corrected visual acuity was good, we found that the outcomes with central as well as decentered cones were equally good. So with appropriate case selection, good BSCVA and appropriate sizing, we can give optimal results in these situations as well. Thank you so much for your kind attention.
Thank you very much, Shreyash, for a very crisp talk. While Dr. Ramamurthy is sharing his screen, I'm going to have 2 questions, one to Gaurav and one to Rajesh and Shreyas. Patient is in the late 20s, Dr. Gaurav. He's come for a refractive correction. Are you there?
Yes, yes.
Refractive correction. So can you go ahead and do a phakic IOL alone and follow up the patient, or would you consider CXL along with it?
So I would not along with it, but if a patient is having
along with it, I meant.
I understand what you meant. So I would definitely look at first stability of the keratoconus. I would not go with the ICL straight away. I mean, even if I have a suspect cornea, I'll want to follow it up to see whether there's changes in the topography and the refraction happening. And only as Shreyas said, I'm satisfied over 6 monthly, 2 or 3 visits, and maybe even more. Only then I would do it. I would not jump to first implanting the ICL and cross-linking. Even cross-linking alone can cause flattening of the cornea over a period of time and change the refraction and even the astigmatism. So I don't think that's a great idea.
Shreyas, your thoughts?
No, I just wanted to say that it is not necessary that every keratoconus has to be cross-linked. So if a patient who is late 20s, early 30s, already you've been seeing this patient for quite some time, it has been a stable keratoconus. So just because you want to subject them to a phakic IOL, it is not necessary they have to be cross-linked. That was the point I was trying to highlight. And you could, if the real rare scenario that these patients progress later after a phakic IOL, you could cross-link them later. Of course, like Gaurav sir said, some of these patients can go on to develop more flattening and haze from cross-linking. But fortunately, with the accelerated protocols nowadays, we don't see as much significant flattening over a prolonged period of time. Rare cases, yes.
One question to you, Dr. Rajesh. When would you consider implanting a phakic IOL in a post-DALK patient? Is it after removal of all sutures or earlier?
Yeah, after removing all the sutures and ensuring a stable topography. So I would say that even after suture removal, at least 3 months post. So we do topography then only when the topography is stable. Because if you don't have a stable refraction, you are unlikely to have a great outcome.
Right. Any other question you all have in mind, Dr. Rajesh or Shreyas, to ask before, because Ramamurthy is going to be the last speaker. I'm giving up my talk because I think we have to close down at 5:25 for the inauguration. So anything else to ask on this very interesting topic?
No, I think what point he has made is very valid, both Shreyas and Gaurav. I think people should not implant toric IOLs, toric ICL in patients with keratoconus who don't have good spectacle corrected visual acuity. Often we see patients who have keratoconus, best spectacle corrected of 624, and they have a toric ICL in the eye. And then when they come back, then to manage these cases, it becomes really problematic. So for me, if I have a patient who's 6/9 or better, which indicates that they have good quality vision with spectacle, then only we think about the option of doing a toric ICL.
The only point,
yeah, it's an off-label approach. It's not recommended by the company, so you have to take that into consideration whenever you are doing it for your patient.
I think just one observation I would like to add is, generally we thought that if it's a decentered cone, then we are not going to take up these patients for toric IPCL or ICL. But what Shreyas showed and what we felt was that, even in these decentered cones, if the patient is having the best spectacle corrected visual acuity of 6/9 or better, you go ahead and implant these lenses till they seem to do well.
Correct. Even if the cone is decentered, if you go and see the power distribution in the pupillary area, often there is not too much of asymmetry within the pupillary area. So the patient can, so you basically not rely on your optometrist, but you have to verify that yourself, that the patient does see 6/9 with the glasses and he's happy with the quality of vision, because that's what he's going to get.